السلام عليكم ورحمة الله وبركاته. شكرا جزيلا دكتور حازم على الدعوة الكريمة وتمنياتي لكم بالنجاح بإذن الله والتوفيق. أنا عارف إن ده سنتر جديد وببارك لكم عليه، فمهم إنه مفيش سنتر بيمشي من غير ما يبقى فيه good team, and a good team is good for everyone. وبعض الناس بتخلط بين المجموعة وبين التيم. A team is a group of professionals who trust each other. A group is a group of people who work together. So the essential element in developing a team is trust. And having a good team will be improving the team dynamics for all, will build leadership, will have problem-solving skills developed, increase the team motivation, attract high-performing employee to join the center, increase the volume and the quality, the word of mouth will be positive and more patients will come to get treated, etc. Just as important as the good team is the mentoring. And a mentor is someone who has more experience, more knowledge, more wisdom, and sincere in getting things into perspective, can guide, can advise, can mentor, can give direction. And within the team, surely some people will be of different seniority and they can impart their wisdom and knowledge into the less senior member of the team. I can't overemphasize the importance of teamwork because you get much more than working single-handedly. There is no clearer example than the team of Professor Abul Ghar, Professor Surur, and Marhuma Dr. Raja Mansour. They have succeeded globally by starting with a coherent team and built on, and we can see them as an example of good and sound and trust inspiring team. When it comes to ethics, if you don't have ethics كالبوصلة بتاعتك وفقدت البوصلة دي is not really good practice and you will regret it because يعني ربنا ما بيفوتش حاجة. ومن يعمل مثقال ذرة خيرا يره ومن يعمل مثقال ذرة شرا يره. واحنا مؤمنين ان شاء الله وعارفين ايه الاكونتابيلتي بتاعتنا. لما تقرا في اي كتاب يكلمك عن البرنسبل اوف ايثكس انك انت we can benefit the patient. If we can't benefit, at least we don't do harm, non-maleficence. We don't harm them. We make them retain their autonomy. If we explain to them something and they don't want, they can't be forced to have. But equally, if they wanted to have something, it must mean that they benefit from it, not just طلبوه والسلام, after explaining and respecting their autonomy. We are expected to tell the truth. Telling alternative facts and stories and all of this is not neither religious nor ethical nor even human. We must maintain patient confidentiality and we must be first and foremost concerned with preservation of life, be it an embryo, be it a baby, be it any human being. And we must practice in a just process. We can't have one size for one group of patients and another size for another group of patients, particularly when it comes to the care that we give and the finances we get the patient to pay. There are so many definitions of ethics. The one that I like is simple. Ethics is doing the right thing. And we all know the right thing. يعني حتى احنا ديننا بيقول الحلال بين والحرام بين. اول ما يعتمل في نفسك انك بتعمل الحاجه دي عشان فيها مكسب زياده ليك دي رونج. اول ما بتعمل حاجه عشان دي اسهل مش الحاجه الصحيحه ده رونج. فthis is ethics in the most simple term. But if for practical consideration you wanted to go through it, we don't do harm, number one. Number two, we respect privacy and confidentiality. We are professional in what we do. العيانة ما هيش خدامة ولا هي أقل مننا، بالعكس ده العيانة هي اللي بتدفع المرتب بتاعنا. يعني without her there is no يعني earning and there is the comfortable life that we lead is thanks to patients. Do what is right, not what is easy. Do what is necessary, not what is random. And do what is appropriate, not what is profitable. And do what add value. مش حاجة كده للسلام عشان كل الناس بتعملها روتين You must convince yourself that there will be added value to doing this test. It will affect the next step. It will improve the success based on evidence, not because you heard it in a meeting. You need to follow the good ethical practice by keeping things simple. You don't complicate things by ordering 101 investigations have no relevance. I am yet to see what is the value of doing thrombophilia screen for patients undergoing IVF. Has no relevance whatsoever. Antiphospholipid antibodies have no relevance, no relationship to miscarriage or to pregnancy or to anything. Only if the patient has antiphospholipid syndrome, that's a different story. But any patient with routine IVF should not have these tests. Practice with integrity and do what you say and say what you do. You can't allow yourself to say I do this and this وفي العيادة وفي الحقيقة تعمل حاجة تانية. للأسف الشديد بعض الناس بتقع في المطب ده. Refer when out of your expertise. لو عيانة قدامك حد تاني هينفعها عارف من خبرته هينفعها أحسن منك تجرد وربنا هيعوضك وابعتها للي ممكن يخدمها أحسن. If you make a mistake be honest. كلنا بنعمل mistakes. We have to explain what went wrong and try to address it fairly and with humility. لأن ما احناش منزلين. When it comes to the practical consideration, what we help patients with is really very simple because for a pregnancy to occur, they need normal sperm that can swim up. They need an egg that is released at the time of ovulation. They need integral structure of the uterine cavity and the tube to do the job. When to investigate is agreed after 1 year of trying. I know في بلادنا وبالذات يعني بلدي هتلاقي الناس بتinvestigate بعد ربع ساعة. It's not fair and we need to reassure them and explain to them it is not because we can't treat, it is because there is a chance you will get pregnant like everybody else without needing treatment. العينين اللي أكتر من 35 ممكن عشان سنهم نعتبر إنهم 6 months of trying and then we can instigate investigation and treat accordingly. The idea of a treatment start with what is less invasive, less expensive and less demanding. If that can do, if عيانة عندها polycystic ovaries, ovulation induction is very successful as long as it's performed safe, it is not as expensive, it's not as taxing, and the patient does not need to have IVF without exhausting the lesser option. If a patient has known cause of azoospermia, for instance, don't need to wait because that requires treatment. We should not investigate if the result of the investigation is not followed by effective treatment. So we don't do tests like effective treatment is not there. But general rule is you can do what you like, provided that what you do, test or intervention adds value to the treatment. If you feel that the patient will benefit from this on material ground, you do it. Important also to follow the order. There is sequence of testing and the clinical scenario and patient preference. يعني أول حاجة بتعملها المفروض السبيرم تيست. مش هتعمل لاباروسكوبي قبل ما تعمل سبيرم تيست. مش هتحضر العين الاي في اف قبل ما تعمل سبيرم تيست. فإف the sperm test is abnormal, don't act on it. You repeat it. But if it's normal, fine. It is reliable because it has high sensitivity. You don't need to repeat normal tests. If you see that the test is abnormal, don't go and say the test is bad. You can never get pregnant with that test because there are so many patients who got pregnant despite abnormal sperm tests. 5% من الفرتايل men اللي عندهم عيال لو عملت لهم sperm test هيطلع abnormal. These results are because the results in the WHO manual are from recent fathers, not a population of men trying to conceive. And it may be inappropriate to extrapolate from recent fathers who are fertile to people who are infertile. Semen parameters are only poorly predictive of conception in subfertile population, unless there is azoospermia. But again, you don't make judgment based on a low count of 10 million. It could be more than adequate for causing pregnancy. No role for routine anti-sperm antibody. There is no established treatment for this. People used to have hip fracture and go into depression due to high doses of steroid without any impact on their fertility or their anti-sperm antibodies. So I hope no one uses this. And I will be grateful if people can be spared spending their money on a test that doesn't add value, such as DNA fragmentation test. It's not diagnostic, it's not prognostic, it has no value. If you really are concerned, you can give the patient antioxidants that are not expensive rather than wasting the money on a test that will be followed by antioxidant or giving antioxidant anyway. So you need to have a bit of philosophy and wisdom for doing what you do. Ovulation, we know all that in a 28-day cycle, estradiol rise in the middle of the cycle, around day 11, 12, will trigger the LH surge, which is essential for maturation of the egg, and will release the egg by ovulation around day 14 plus or minus 2. And then the mid-luteal progesterone, which is the basis for us testing for ovulation. And then if there is no pregnancy, the menstruation will follow. Now, this is known for all of you. But a patient who has regular 28-day cycle, if she alert and keeping a diary, probably does not need this because most likely her cycle is ovulatory. This one that can be misinterpreted. You do a patient AMH because she has been trying for 2 months and she didn't get pregnant. You find it is low or modest. You tell her, no, you must go now for IVF urgent. ممكن تبعتها لقسم الطوارئ عشان تعمل IVF urgently. That's totally unnecessary, obviously, because a big study was published 10 years ago, more than 10 years ago, looked at patients who have not tried to conceive. And they looked at those who have high AMH, normal AMH, or low AMH, and looked at their fecundity over the years. You can see the line is identical for the 3 groups. So those who are trying to conceive naturally without infertility, you can disregard the level of AMH. And a patient who has ovulatory cycle does not mean that her egg reserve is fine, because those who with low ovarian reserve can go ovulating until they are in their mid-40. Testing the tubes need not to be taxing. The HSG reliable and can give us useful information and not as expensive and as invasive as laparoscopy. Although laparoscopy will give you more money and will give you more control, but does this really serve the patient purpose? And some of us here, we do hycosi or hyphosi, where we put some contrast material and do the scan, and you can see the tubes patent and the spill. If you don't have it, if it's more expensive than doing otherwise, don't use. Just by talking about HSG, in actual fact, it has some therapeutic edge. If you use lipidol, it was found to be leading to higher pregnancy rate after doing the test by clearing very subtle adhesion or something like this, compared with using urographene or water-based contrast. Yes, finding laparoscopy finding endometriosis incidentally and diathermy and cauterizing may enhance fertility, but it's no justification to do laparoscopy for every patient. Only if she has symptoms suggested she has endometriosis while she's infertile, you might do the laparoscopy to confirm the diagnosis and to treat those superficial implants, because there is evidence that they can improve, but not an indication to do routine laparoscopy for every patient. Good utilization of ultrasound imaging reduces the need for invasive diagnostic procedures. Ultrasound imaging, it is very helpful, and all of us have ultrasound machine, and what you see is what you get. You don't need anything else to tell you that this lining is beautiful, it has right pattern, it's right hormonal environment, end of the story. If you have 3D and you have this image, it's telling you everything you need to know about the uterine integrity. If you are in doubt and put some fluid in the cavity of the uterus, you can get a clear indication of the cavity of the uterus. There is no polyp, there is no small fibroid, you are clear. And the same here. Even a simple 2D scan can tell you that this and the endometrium is abnormally thin. And if I am seeing a patient of mine with this figure, I say, you know what, there is a possibility of chronic endometritis. I will not waste her money sending her to have hysteroscopy and to have biopsy and to be sent for CD138. No, I will give her a course, 2 weeks of doxycycline, 100 milligram twice a day, 2 weeks. That will cost her next to nothing. And if she has chronic endometritis, this is a treatment. If she has something else, it will become clear after I treated this. If it's still persistent, then I send her to someone who is expert in laparoscopy in case she has adhesions that you can't see, you can't correct. Please do not improvise, because you can do more harm than good. If a patient has subseptate uterus, we need to make considered judgment. Not every patient, not every septum need to be removed. And the study showed that patients with septum can conceive just as those who don't. But if a patient has failed cycle, history of miscarriage, you also send her to someone who can do a good job. The patient has a polyp, it needs to be removed before expensive treatments such as IVF, and that where office hysteroscopy can be handy. Here is imaging, give you an idea. This submucosal fibroid need to come out. This one not necessarily need to be tampered with, and not necessarily needing abdominal myomectomy or laparoscopic myomectomy for this, because that one is the most relevant to the outcome of treatment. Again, intrauterine adhesions by saline sonography. Again, just simple ultrasound scan is telling you that this endometrium has all the hallmarks, the myometrium of adenomyosis, endometrial cyst, heterogeneity, and stria here, all those shadows. And this patient will know from that simple scan that she has adenomyosis, and you counsel her accordingly and you instigate the right treatment. You can use hysterosonography to delineate whether the fibroid is distorting the cavity or otherwise. But again and again, a simple image like this gives you all you need to know about a clear uterus. If you do the ultrasound scan and you can see a figure like this, your diagnosis of hydrosalpinx is meaningful, and this patient needs a laparoscopy to disconnect the hydrosalpinx proximally or to remove it, whichever you use. Although now, personally, I disconnect because the hydrosalpinx is not cancer, and avoid any dissection that could interfere with the ovarian blood supply. But if you do one or the other, as long as you don't do more harm, it's fine. Hysteroscopy is meant to be for intervention, really. To use it as a diagnosis in the presence of good ultrasound machine is unnecessary, because how else would you treat things like this? This is normal hysteroscopy. You don't need to do a hysteroscopy to prove normal. You can do that with ultrasound. But with that, you can only do it with hysteroscopy. Nobody will argue. Polyp, you can only do it with hysteroscopy. Septum, if this clinical situation require resection, you can do it only with it. Adhesions, etc., etc. So this is the dilemma. When patient demand test and prescription, doctors should think twice. You are not in a supermarket where you give the patient everything she asks for. You need to respect her intelligence. Explain to her why wouldn't you agree to give her this, even though you could stand to gain commercially or monetary terms, but you don't want to give her because it's not good for her. It will not add her to her chances. The patient will sense the honesty and they will go nowhere. But just because everybody does it, it doesn't mean it is right. Many patients demand tests, and often doctors encourage them. That is bad practice. All of this exacerbated when there isn't a strong doctor-patient relationship. If you haven't established a rapport with the patient, you have not gained her confidence, she will dictate on you what you should do. That is very anomalous situation. I would never, ever, ever accept that the patient asking for a procedure or a treatment that I don't believe that it helps her. And they can go wherever they like. The only true story is they don't go anywhere when they see you confident, knowledgeable, not arrogant, and caring for their interest, not for your gain. Concern for patient and malpractice anxiety are not the only reason for excessive testing, unfortunately. Because some people say, I'm doing the test because if the patient miscarries, she will blame it on me. That's total nonsense. That's not medicine. If you did act within the evidence-based grounds, then you can defend anything that you do. Sadly, we go into almost malpractice here because some doctors, whoever test, are motivated by financial self-interest. People get commission from the lab. They may own the lab themselves. That is not ethical. That is not legal. That's not even براعي ربنا حتى. لان ايه اللي اكتسبته عشان تاخد فلوس الانفستيجيشن؟ ما تخلي الراجل لو انت فعلا يعني الضمير متوافق، خلي الراجل يدي لك خصم عشان عندك فلو كويس، عينينك يدفعوا اقل، على الاقل يبقى وفرت لهم حاجه عشان يعرفوا يدفعوا اللي بيدفعوه عندك. لكن ده in my book لا شيخ ولا معلم ولا اي حاجه. كل اللي بقوله لكم ان لا يمكن في حياتي I consider doing something like this. لأن ده التعريف الحقيقي للسحت. Extra tests tend to lead to more procedure, which means more money for the doctor. That money is really suspicious. To avoid the clash between the patient, improve your communication with her, give her treatment that suit her circumstances, not routine for everyone. Improve accessibility of care. If you make life easier for her in terms of expenses, removing unnecessary investigation, she should have the finances to try again rather than doing one and then being left hang to dry. The burden of IVF treatment is multiple: emotional, financial, and medical. The patient will be stressed. Will IVF work? Will the treatment cost be worth it? Am I doing this for good result or I will be empty-handed? Plus the emotional stress where حماتها بتقول لها امتى العيل، جوزها بيقول لها العيب فيك مش فيك، الحاجات دي احنا عارفينها. فالمفروض العيانين يستحقوا السمباثي والسبورت, not squeezing them dry of money. So what is our role? Conceptual, practical, and ethical. We need to treat patients as collective, not just the ovary or not just the AMH. No, we need to consider their psychology, consider their demand, consider their social background, consider their educational background, advise them on what is relevant to their circumstances. We counsel them about the indication. Why are we doing the procedure? What's the benefit? If we didn't it, what is the harm? If we didn't do it, the steps of the procedure. It will involve this and this in the best possible way. What is the pregnancy rate in our center in general and for their condition? If a patient has low ovarian reserve or she is 40, what is the result in my place? Not give her something to increase her expectation and so doing increase the disappointment or intensify the disappointment. What are the side effects and what will you do to avoid them? What are the complications and what you, from your experience, have had them or not? That will be reassuring. Financial information, what the treatment costs, and if patient can read or have relative who can read that for her, give her something in writing. Stay focused on what is fundamental. Losing sight of what is essential is costly. And fundamental don't change. Age is the most important prognostic factor. Telling patient who is 44, I will make you pregnant, that is cheating and يعني حلحوش. الحاجات اللي بنشوفها في الفيسبوك لو الاي ام اتش بتاعتك زيرو، لو انت 50 I'll make you pregnant، ده عباره عن نصب واحتيال. ممكن يقفوا في محطه مصر ينشلوا ارحم من اللي بيتعمل ده. ال FSH not as fancy as AMH, but it is as reflective of egg reserve almost, because if it's done on the second day of the cycle, at any age when the FSH is high, when it reaches 15 or more, look at the chances of pregnancy. They almost hit zero. And that's established since 1988. So لو عيانة يعني ما عندهاش الفاينانسز انها to do AMH, bring her on the second day of the cycle and do FSH, LH and estradiol. You will find the estradiol is basal. If the FSH is 15, it gives you helpful counseling tool. If it is 4 or 5, it gives you a helpful counseling tool. Your egg reserve is fine. And I will do the scan, which will show me your antifollicular count. So she doesn't need to invest in AMH. The age is important. Whether the treatment happened في قنا ولا في San Francisco, the same. Look at in America, under 35, the chance is less than 40% leaving the clinic with a baby. By 40 to 41 is around 10%. 42 is around 30%. And this is the truth, unfortunately, not the figures that we make up by talking about 90% and 95%. And we hear people and colleagues really that they should know better than this, who say, my results are 88%. You're making it up. There is no 80%. Or those who said, consider the patient has failed and give her all the investigation to cover this. That is, I can't even describe it. It is ignorance, it is arrogance, it is greed, and it is unethical, because everybody is innocent until proven guilty. We always give the standard treatment and give the standard investigation. And the majority of patients will get what they wanted with proper counseling. If not the first cycle, will be from the frozen embryo. If it's not from the frozen embryo, from second attempt. That is biology. There is no magic. And why? Because the treatment is costly. And it is very important to consider this. If you are doing a test, what difference does it make? What is the impact on the next step? So if you find an ovary like this on ultrasound, why should you need AMH? It's telling you all you need to know. This patient has high AMH because there's no polycystic ovaries with high AMH. This patient will require ovulation induction first with oral letrozole. If it doesn't work, you can move after 3 cycles, if not more, to using the step-up protocol with gonadotropin. If it doesn't, then you can consider IVF or whatever. But you have to be rational in what you do. Again, why do you do hysteroscopy? To show that the cavity is normal, because the ultrasound is giving you the same information. Do we need to prescribe heparin for IVF patient? This is where I feel like screaming, like this gentleman or this piece of art, because we did that work long time ago. We found the observational study showing that it worked. The proper randomized control trial showing it does not help anyone. All the guidelines now show that heparin add no value to IVF patients. But people do not have the conviction or the belief or the confidence to do what is right. They do what is easy. But have you considered that the total cost of a course of heparin, if the patient happened to become pregnant, you know better than me, it would be probably about 25, 30,000 pounds. Who does have 30,000 pounds not knowing what to do with it? Don't we have a social role in terms of considering the circumstances of the patient? You ask someone, why are you using this? It can't happen here. Nobody will consider giving heparin. I have not prescribed heparin ever, except for a patient who's coming from the hematologist with hematological condition require heparin. Other than that, never. But when you ask one, why are you doing heparin when it doesn't add value, say other places use it. So and وانت بسم الله ما شاء الله ما عندكش اي خلفيه قريت ولا evidence does not exist. Patient requested and I can't say no. Are you working in a supermarket and the patient coming to have 2 kilograms of potato? This is your responsibility. I used it and my patient got pregnant. Does this mean that got pregnant because she had this? يعني اي حد نايف مش لازم يبقى دكتور يقول لك ان دي حاجه كوينسيدنتال ملهاش علاقه باللي انت عملته، مفيش بيولوجي يفسر ليه حملت. I read the paper and it showed that it works. ده كلام فاضي، لان لو صدقت كل اللي بتقراه يبقى انت عليك السلام. لازم تبقى discerning وتاخد الحكمه من الناس اللي تعرف والناس اللي بتقرا كتير، وانت تقرا كتير. ودلوقتي كل حاجه متاحه، ممكن تبحث بنفسك هل البيبر دي اصدقها ولا فيها methodological issues ولا integrity issue تخليني ما اصدقهاش. You might say there is nothing else I can do. مين اللي قال لك لازم تعمل حاجه؟ Doing nothing sometimes is the best thing you can do. If I don't do this and the treatment fails, patient will blame me. ده مش medicine. ده لان ما حدش بيضمن النتيجه. مهما اديتها ان شاء الله تديها حتى يعني TNT مش هتضمن النتيجه. If she will blame you for failure, she will blame you for the majority of patients. الا اذا كنت انت ساحر. I use him after the first cycle failed. ده للاسف reflect ignorance، لانك تخيلت ان بعد سايكل 5 كل العينين هيحملوا. ما حدش يقول كده الا اذا كان مش عارف او مش متعمق في الموضوع بتاعه او فكرته سطحيه. Inadequate knowledge or understanding are responsible for all of this. Again, some people will say doing something is better than nothing. No, doing nothing may be better. Unless if what you will do is harmless, it is costless, and it will not ensure any added burden for the patient, fine, that could be a placebo, I am with you. But you can't say doing something is better than nothing if it will cost her the money that she could use for another cycle or she pays for freezing. Otherwise, she will go bankrupt. If you happen to do anything, whether it's intervention or test or treatment, because it gives you more money compared with the alternative, then that is called conflict of interest. And you need to check your conscience. And when you get to go to get the carpet for prayers and تواجه القبلة وتقول اهدنا الصراط المستقيم تذكر انك ده مش الصراط المستقيم لانه selfish, cheating and misleading for your own gain. Why not? Because it is the wrong reason, it is the wrong assumption, it is the wrong impact, because the patient will be bankrupt before you completely satisfied with a lot of money. Evidence-based medicine is not made for the West. It's made for everyone who is discerning عنده ضمير. لازم تبص في الجايدلاينز. If guidelines say this thing doesn't work, you should take it. Because people who are experts sat around the table, scratched their head, have read everything and dissected and gave you something on a plate. To go against it, you are arrogant or ignorant or both. Something like this. 13 years, the American Urological Association and the American Society of Reproductive Medicine have not recommended the use of sperm DNA fragmentation. That has since been repeated in so many cycles, in so many studies, in so many Cochrane review, but people are still doing that useless, unhelpful test that does not add any value to the diagnosis or to the prognosis. Platelet-rich plasma to help patients who are menopausal or to help patients with zero ovarian reserve. That is أكل أموال الناس بالباطل لأنه لن يعيد الساعة إلى الوراء ولن يحسن جودة ما تبقى من بويضات في واحدة سنها 44 سنة. دي حاجة ربنا خلقهم بكده، يعني حكمته اقتضت إن الرجال يبقى عندهم مصنع لأنهم بيعملوا سبيرم لغاية ما يموتوا، وإن السيدات يبقى عندهم وير هاوس، عندهم مخزون مجرد ما يخلص خلاص. اقتضت حكمة ربنا، ساعات يخلص بدري، ساعات يخلص في ميعاده، ساعات يخلص متأخر، لكن دي ملناش دخل فيها وما فيش أي evidence محترم بيقول البليتلت بلازما will reverse the clock or will improve the quality of the eggs in a patient who has. Now, all of these have been produced to us from ISHRA guidelines, from other people. Endometrial scratch does not do anything. I'm sure people do it because it will give them money, but this money is questionable. Intralipid, IVIG, immune suppression, giving PRP infusion in the uterus, giving HCG, low molecular weight heparin, assisted hatching. كل الحاجات دي ثبت بطلان فعاليتها، وأي ماني بتتاخد من العيانين أو العيانين تدفع في دي، يعني الواحد لازم يسأل ضميره في الحكاية دي. How to reduce the burden of IVF and increase the success? Focus on the essential. Don't lose sight of what is important. لازم تبقى واعي بأي stimulation you'll use، بأي you are skilled with your egg collection. You will not leave half of the eggs behind. You will do it safely. Your lab is competent and will provide the right environment for the eggs and embryos. Your procedure of embryo transfer is diligent and delicate and directed and expert, and so on and so forth. You are using the extra embryos effectively to freeze, because the cost of frozen embryo transfer cannot equate to fresh embryo transfer. These are the essential. So IVF is not rocket science, but requires sound knowledge, adequate skills, and above all, professional and ethical attitude. And let's remember that some patients after IVF fail, they go on to get pregnant on their own. This is a French series was published 10 years ago. 400 women were followed up after failed IVF. They found that good number of them got pregnant spontaneous. 30% got pregnant spontaneously in the observation that follows failed IVF. And we must do everything possible to avoid exploiting patient غلابة، سواء في هنا أو سواء هناك أو سواء في أستراليا أو سواء في الفلبين. Patients don't print money. They struggle to find the money. And if we don't show empathy and sympathy with them, we have lost the human side of medicine. And finally, I use the opportunity to acknowledge my team and to show you that I would have gone nowhere without the team. And of course, كله بفضل الله, لكن to have a good mentor in this guy has helped me a lot, and I keep now doing the opposite by mentoring the team that I am in charge of, because that is how success and honesty and integrity can be propagated. Thank you very much.